All right, today we're jumping into a real high-stakes medical mystery. You know, the kind that starts off looking like a textbook case in the ER, but then it spirals into a crazy race against time. And it all comes down to one single question. Let's dive in.
Yeah, this is a perfect example of what doctors call a diagnostic trap. It's one of those situations where the easy, obvious answer is staring you right in the face, but it's the wrong one. And if you miss the tiny little clues, the consequences can be, well, pretty devastating. So we're going to break down exactly how this trap gets set and, how to sidestep it.
So let's set the scene. Our story kicks off where so many of these medical dramas do, the emergency room. A patient comes in and they have this cluster of symptoms that's screaming a very common and very serious diagnosis.
Okay, so our patient is a 45-year-old woman, and she's got the 4 classic signs. We're talking colicky abdominal pain. That's that awful pain that comes and goes in waves, right? It's the bowel literally fighting against a blockage. Then you add vomiting, you add that bloated, distended belly, and something called absolute constipation, meaning nothing is getting through. The whole picture seems pretty cut and dry.
So everything is pointing to a small bowel obstruction, or SBO for short. This is a diagnosis that gets made all day, every day in hospitals everywhere. It seems super straightforward, but this is exactly where our story takes a huge twist. This is where the real detective work has to start.
See, whenever a doctor suspects an SBO, there's one question they absolutely have to ask first, before anything else. And the answer to this one little question, well, it changes the entire game. It's the key that unlocks the hidden danger in this whole case.
And that all-important question is simply, have you ever had surgery on your abdomen before? I know, it sounds almost too simple, right? Maybe even trivial. But trust me, it is the single most important piece of this entire puzzle. So what do you think? What was her answer?
The answer was no. She's never had any abdominal surgery. And that one little word, it changes everything.
Okay, so here's why that's such a bombshell. The #1 cause of small bowel obstructions by a long shot is something called adhesions. That's basically internal scar tissue that forms after surgery, and it can twist or kink up the intestines. But here's the thing. If you've never had surgery, you're not going to have adhesions. So our #1 suspect is officially off the list. We're back to square one.
So, with adhesions ruled out, the whole way you look at this problem has to change, and fast. You have to start thinking about a whole different and, frankly, more dangerous list of suspects. This is what's known as an obstruction in a virgin abdomen. And no, that's not a weird term. It's a real clinical term for an abdomen that's never been operated on. So, what's on this new list? Well, you've got things like an external hernia, maybe a tumor causing a blockage, or a scary twisting of the bowel called a volvulus. But the one we're really going to zero in on today, the real culprit hiding in the shadows here, is the internal hernia.
Now, this is what makes it so tricky. When you think of a hernia, you probably picture a bulge you can see on the outside, right? But an internal hernia is totally hidden. It's when a piece of the bowel slips through some kind of abnormal opening inside the abdominal cavity. Maybe a little defect someone was born with. It's basically a hidden trap, just waiting to be sprung.
And when that trap does spring, oh boy, it doesn't just block things up. It creates a situation that is way, way more dangerous. We're talking about a full-blown surgical emergency with a very loud, ticking clock.
This nightmare scenario is called a closed-loop obstruction. And the best way to picture it is to think of a garden hose bent into a U shape. Now imagine kinking it at the entrance and the exit. See? Nothing can get in, nothing can get out. The pressure inside that trap loop builds up like crazy, and that's what makes this so incredibly dangerous. So the question is, how on earth do you spot this thing if it's hidden inside? Well, on a CT scan, there's a classic clue that radiologists are trained to hunt for, and it has a pretty cool descriptive name, the mesenteric swirl sign.
So what is this swirl sign? Basically, that swirl is the mesentery. That's the fatty tissue that holds your intestines in place and, crucially, carries their blood supply. It's literally twisting around on itself like you're wringing out a dish rag. And that twisting motion, it chokes off the blood vessels. So this isn't just a plumbing problem anymore, it's a vascular emergency. The tissue is being starved of blood.
And the second that twisting happens and the blood supply gets cut off, the race is on. We are officially desperately racing against the clock. A really destructive and potentially irreversible process has just kicked off deep inside the patient's body.
So let's walk through exactly how this turns so deadly, step by step.
First, the loop of bile gets trapped. Simple enough. But then, the low-pressure veins get squeezed shut first. Think about it. Blood can still get in through the tougher arteries, but it can't get out. So what happens? The bowel wall starts to swell up with trapped fluid. That swelling gets so bad it eventually pinches off the arteries too. And now, no blood can get in at all. That's when the tissue starts to die. Necrosis.
And here's the truly terrifying part. This whole cascade, from a healthy piece of intestine to a dead, gangrenous one, can happen in a matter of hours. Not days, hours. There is absolutely no time for a wait-and-see approach here. This really puts the urgency into perspective. Look at the difference. On the right, you have your typical adhesion blockage. It's often partial, it might get better on its own without surgery. But on the left, our internal hernia, that's a sudden, complete obstruction. The blood supply is in trouble from the get-go. It's not a maybe surgery, it's a get to the operating room now surgical emergency.
All right, let's nail down the key lessons here. Quick recap. Takeaway number 1. Let's go all the way back to the beginning. What is the single most common cause of an SBO overall?
You got it. Adhesions from a previous surgery. That is the number one answer. That's the rule. But as we've just seen, the best doctors are the ones who always know the exceptions to the rule. And that brings us to the most important lesson of this entire case. What should be at the very top of your list when you see a patient with a bowel obstruction, but they have that virgin abdomen, no surgical scars?
A hernia. Plain and simple. It could be an external one you can feel, or it could be one of these sneaky internal ones. Either way, that has to be your primary suspect. That is how you avoid falling into this diagnostic trap.
So let's leave it with this final thought. We've just walked through how a case that looks totally routine can turn into an absolute catastrophe in just a few hours. So how does knowing this, how does knowing about this deadly little trap change how we approach any patient who comes into the ER with bad abdominal pain? It's a powerful reminder, isn't it, that sometimes the most important clue isn't what you see, it's what isn't there.